Marie Muller is a professor and the principal investigator in the Ultrasonic Material Characterization Lab at North Carolina State University. Marie, thank you so much for taking the time today.
Thanks for inviting me.
So, to start, could you tell the audience a little bit about your research?
Yes, so I do research in biomedical ultrasound. Almost everyone knows about ultrasound imaging and ultrasonography. What we do is we try to push this a little bit forward by doing quantitative ultrasound. So we extract, instead of just doing images, we tried to extract quantitative information out of the ultrasonic signals so that we can have numbers in addition to images. And that's especially useful for chronic diseases when you need to monitor, see if something is getting worse or better, look at response to treatments. So it's a subfield called quantitative ultrasound.
Awesome. And what are some of the challenges associated with conducting this research?
Um, well, um, so ultrasound is a mature field, right? It's been invented and used for medical imaging for a couple decades now. And so I always joke that we end up with what everyone considered noise before, because everything else has been done. So what is really hard is that, what looks like noise is actually signal, is actually information. And what is a little difficult is to use the physics of wave propagation to connect what we see in the signals to what happened in the tissue. And we do that a little bit like geophysicists do or seismologists do with earthquake signals. They record those long, long signals, and then they solve what we call inverse problems. They know the physics of propagation, and they make conclusions on the structure of the medium, right? Whether it's the earth, they can know more about earthquake triggering, what happened to those waves. We do similar things, but inside the human body, and we try to draw conclusions on, how much aeration is in this lung, how many vessels are in this tissue. Is there a lot of fibrotic tissue? Or is there a lot of uh, fat in this liver? All these parameters that we can measure from ultrasound signals.
So, what are some of the applications of this research? You mentioned the different things you can see, like within the vessels and the tissue and the fat. How do you use that data or information? What do you apply this to?
Yeah, so as an example, so the specificity of what we do is that it's quantitative. And so that lends itself really well to monitoring chronic diseases. And if you combine that to a new revolution that is happening in ultrasound, which is the advent of wearable ultrasound devices, you're now with a technology that you can wear at home. And I should say, I don't design wearable ultrasound devices. I really work on wave propagation and ultrasound data. But if you combine quantitative ultrasound with wearable ultrasound, with machine learning and AI, then suddenly you have a technology that can give you numbers. So that's, if you have a chronic disease, you can monitor yourself at home, instead of, having those repeated appointments at the clinic or the hospital. You can compare your numbers to last week, last month, and adjust your treatment and do easy measurements. So a couple examples of applications of diseases that we are working on in my lab are lung diseases that are chronic, such as pulmonary fibrosis. We recently demonstrated that we can measure the severity of fibrosis using those ultrasound signals. And if that could be measured at home, then it would be a much easier way to adjust treatment. Another potential application also to chronic diseases is vascular diseases. We know that it's extremely common and lifelong most of the time. We're working in my lab on building an implantable ultrasound device to measure vascular flow in patients with peripheral arterial disease, because we know even if they get care, even if they get surgery, we know that the surgery is going to fail. That's just the nature of vascular surgery. But you never know when, right? And that's again the beauty of having a number that you can read, that anyone can read, not a highly skilled, highly trained operator. Then you can monitor yourself and you can, have these devices as, a companion to track your chronic disease. So I gave you the example of lung fibrosis, vascular diseases. We also work on pulmonary edema, which is often a consequence of heart failure, which is also long-term, although it has acute phases. Other people work on liver fibrosis and fatty liver disease. We don't do that in my lab currently, but there's many great teams that work on that. And
Yeah.
and also osteoporosis is another one. We work on bone monitoring, but other groups also do around the world.
So are these implantable devices, are they similar to something like a stent, or what do these look like, and how do they get implemented in practice?
So the way we envision it, and we're still at the prototype phase for that implantable vascular monitoring device, the way we envision it is a subcutaneous device. So it's not as invasive as a stent. It doesn't go inside the vessel. It stays under the skin, which makes it easier to insert, and can potentially, makes it possible to be implanted in more people. And I should say inserted actually, because it's really subcutaneous. And then it works like a conventional Doppler device.
Wow. So what are some of the dynamics with remote medicine and these wearable and implantable devices? How do you think about that work and some of the trends and how it's changing?
Yeah, so there's many aspects of that. There's a lot to unpack about this, and I've been thinking about these issues quite a bit recently because we're working on this implantable device, and because I've been thinking about wearables more and more. But there's many aspects that I think we should consider. One is obviously the question of, privacy. There's a lot of data that is generated, both with, wearables and also in the future with implantables when they're going to become more and more common. Uh, what do we do with the data? Um, then there's also a question that really matters to me, the question about dignity. So when you consent to having something monitor you, but you can't take it off, what does it mean? There's a lot of stigma that is associated with some diseases, and people should be allowed to have suboptimal behaviors sometimes, and without anyone noticing, right? And so this is actually something that I truly became aware of when I did this program at MIT in January. It was on opioid use and how we could come up with technology to address that issue. And there's, of course, many aspects of that issue. There's the addiction, there's psychosocial aspects, there's so many pieces. And I came, with the idea of an implantable, and when talking to experts in the field, it quickly became obvious that no, you shouldn't do that. People, getting better is actually, relapse is part of getting better, and people should be allowed to go through that with, privacy and dignity. So that's a big one to me with implantables, and something that I really want to, think about when we design our device. And then another one is sustainability and potential for upgrades, right? So technology evolves all the time, and how reversible is inserting the device when you design it, you should really think about that. How can you upgrade it? So that's another big piece, right? Where we should, I think, really try to protect patients, not by not doing it, But by, designing around this, you don't know your future self. Reversal can be expensive. It's hard to give consent in the long term. So yeah, this aspect of, upgradability and reversibility and long-term consent is something that should be incorporated in how we create these technologies. So that's another piece that interests me a lot. Um, and then of course there's the issue of data overload, right? So we have so much that we measure now. You can measure your blood glucose when you don't have diabetes just because you want to know yourself better. And ethically, maybe there is a point where this is too much. And also maybe technically, there is, maybe for the clinicians who, when you're monitored for something that can be life-threatening, who has the data and who's liable? If your numbers change and you're at risk for amputation because your vessel is narrowing really quickly, who receives that information and who's responsible for doing something about it?
Mm.
I think we should really think about how we design our technologies about that when we design them. uh, And there's the actionability. There are many things that we can monitor that are useless. And I hear that it sounds like I don't like wearable and remote medicine. I love it. I think it's the future of medicine. I don't want to sound anti any of that. I do quantitative ultrasound because of that, because it lends itself so well to to remote and more equal access as well. Uh, and again, I think there's a lot of psychological and social and liability related and privacy related aspects that we should account for.
Yeah. I'm curious on the on some of the dynamics that you mentioned. Is it the case that the many of the implantable or wearable devices are also connected to something like a phone or another personal device that where data is also of a concern that you want to have something actionable, but it's also some of those things that you laid out are also present?
For sure. So the data needs to go somewhere, right? So usually it goes, on the cloud. It can be processed actually directly on a remote server somewhere, right? So we know pretty well how to protect that data and how to make it safe. We just need to be able to guarantee that it's going to be safe. There's a lot of processes that make it like HIPAA compliant. So the technology makes it possible. Uh, we just need, as people who design these technologies, we need to show we care about that, and that we're going to put it at the forefront of our design.
Yeah. I'm also curious about the just in within remote medicine, these implantables and wearables for elderly. I would think that elderly more or are more likely to have health moments that require assistance. And I remember a while back there were like advertisements for buttons that elderly would wear around their neck to, if there was an emergency, they'd press it. Is that something that you're seeing more with these wearables and implantables that they're able to, alert somebody if something's going on and then they're able to get attention in a more timely manner?
Yes, for sure. That's a great use, right? Because that is highly actionable, right? So, somebody fell. That is a highly, highly actionable information. And so that is a great example to me of, that kind of remote information and that kind of need for, remote access. Um, it's also true for in the case of vascular disease, for example, it's a disease that affects elderly population more than younger populations. And first of all, it's a population that is not as compliant.
Mm,
But it's also hard. It's also hard to get undressed when when maybe you're in pain or you're much older. And so just getting inside a clinic and getting undressed to get a Doppler done, for example, where it could be done where you while you're watching TV at home. And by the way, you don't have to remember to do it. Or maybe your phone gives you a notification that you need to scan and you scan. Um, that is a great example of how, again, it's all about, you have devices that are life-sustaining. Well, then it's not a question, right? A pacemaker is a pacemaker, and without the pacemaker, people, would die. And this is absolutely a no-brainer. It should be inserted. Then there's the case of highly actionable, information where I think it's very crucial to have, and it really has added value. And this is exactly where I try to work. Um, and then there is the case where the information is maybe less actionable, maybe not life-sustaining, and it's still fine, but people have to be really aware when they consent to that, of what they're giving and who has the information.
mm,
Um, and this is especially true with implantables because you can't take it off.
mm.
I can take my watch off anytime if I don't want anyone to know that I took no steps today. But if it's something in my body, I can't. And so we just have to be aware of that.
Yeah. There's another thing that you mentioned that I wanted to follow up on. You mentioned the sustainability and kind of the ability to upgrade some of these things. I'm curious if there is kind of a development in materials or thinking about how things change over. I don't know how long these will be implanted for, but the body changes, the materials might degrade, like all these different dynamics. How do you think about that, and how has that been changing over time?
Yeah, so there's I think three aspects of that, right? There's the long-term biocompatibility, and that's the basis. Of course, the thing should not leak lead into your body after 5 years, right? And that's kind of an easy one because it's so obvious, although for some materials, we don't necessarily have long-term biocomp information, but there are many for which we do. So that's the first level. Then there's the software upgrade. And so, I think we should design our technologies with that in mind and make sure that either most of the software is dematerialized, is outside of the device somewhere else, or at least upgradable, through the body. And then there is what if we come up with a much better idea in 10 years, something that will make this device irrelevant? How reversible is it, right? How easy and safe is a procedure to remove it? So to me, these are, three distinct aspects, and we should, move the needle on all of them at the same time.
Yeah. So the last question I want to ask you is, what does the future of this work look like? And do you see any breakthroughs on the horizon?
Yeah, so in terms of technological breakthroughs, I think we're going to see a lot, and I know ultrasound really well, so that's what I'm going to talk about. I'm sure there's a lot more in other fields, but a lot of a lot of patches that you can use to monitor your heart, for example. Um, Things that you can wear 24/7 so you can catch maybe rare events. That would be a great breakthrough. There's a lot of research and there's a lot of prototypes, uh, but I think it's going to, be translated, very soon, and that's a very exciting prospect. Then there's the implantable world that I think is also really moving forward. Um, in general, all of that, if nicely done and if ethically done, to me, this leads to a lot of agency for the patients. Yes, too much information can be too much, but taking your own health, into your own hands and getting the data that you need to call your doctor if needed, change your diet if you need, change your treatment if you need, and being part of that process because it's at home and not, on that big scary machine that only this highly trained person can read. I think that that can potentially lead to a lot of agency, and that's really what I love. I also love that ultrasound is so low cost, and 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 so portable. We've talked about that because this is, so many more people that can potentially be treated or monitored for a fraction of the cost. And there's a lot of potential benefits to that.
Yeah. Well, Marie, thank you so much for taking the time to talk to me and for sharing your research and your insights. And I hope we can continue the conversation down the road.
Thank you so much.